Assalamu alaikum wa rahmatullahi wa barakatuh. We will continue with SLE. So next, management of patient with SLE. We start with simple advice to the patient. Number one, continuous sun exposure or excessive times of sun exposure should be prohibited because, as we mentioned earlier, UV light can exacerbate the disease, and if patient go to a long time into sun exposure, he should wear sunblock. Another advice, estrogen containing contraceptive pills should be prohibited for ladies, childbearing ladies, and should have alternative mode of contraception. Because these people are high risk of cardiovascular complication, we say cardiovascular disease is the main cause of death among patients with SLE. So risk factor for cardiovascular disease such as hypertension, hyperlipidemia should be looked for and actively treated, aggressively treated to prevent these complications. Number 4, advise all patients to stop smoking. Now, what about pharmacotherapy? We will divide the disease into mild, moderate, severe. In mild disease, where only there is involvement of skin and joints, preferable treatment is simple analgesia like non-steroidal anti-inflammatory drug on need and hydroxychloroquine. Hydroxychloroquine is now the cornerstone in the treatment of all SLE patients. One of its major benefits is to decrease the incidence of flare-up of disease. So hydroxychloroquine should be started in all patients indefinitely. But if this patient does not get better, or there is poor response to this medication, or the patient has moderate severe disease, so we need to scaling up with medication by adding steroid in low dose with 5 to 20 milligram per day, plus minus immune suppressant medication like methotrexate, azathioprine, or mycophenolate mofetil. In severe disease, and to define severe disease is SLE that characterized by involvement of renal, nephritis, cardiac disease, or CNS involvement. These three system organs define severe SLE and need to be treated rapidly and aggressively because it's life-threatening condition. So if the patient has severe disease, treatment will be started immediately with high-dose IV glucocorticoid in form of pulse method prednisolone, 10 mg kg IV per day for 3 consecutive days. Then we convert it into 40 to 60 mg prednisolone for a long time. And plus to the steroid, we should add another immune suppressant medication, which could be either cyclophosphamide in a dose of 15 mg per kg per a dose. The dose should be repeated every 2 weeks for 6 cycles, or mycophenolate mofetil. So we have to choose between cyclophosphamide and mofetil. Recent studies state that these two drugs have the same efficacy in treating acute exacerbation of SLE, but keep in mind, more severe disease or SLE in a black population, or when there is CNS involvement, cyclophosphamide is preferable over mycophenolate mofetil, while in young age female, which is childbearing age and no CNS involvement, mycophenolate is preferable because cyclophosphamide will interfere with fertility and cause infertility. Following the control of acute disease, the patient should be continue on high-dose oral prednisolone, 40 to 60 mg, and gradually reduce it to target 5 to 15 mg over a period of not less than 3 months, plus adding steroid-sparing agents like azathioprine, methotrexate, or mycophenolate mofetil as we described earlier. Now, a special situation related to systemic lupus erythematosus, there is an entity called drug-induced lupus. This is a syndrome of fever, malaise, arthritis, skin rash, plus minus serositis, and positive antinuclear antibody, and history of recently starting a new medication. So, a drug causing lupus. In contrast to SLE, drug-induced lupus has less female predilection. It is rarely involved the kidney or the brain, and almost never associated with anti-double-strand strand DNA. When we need to investigate these patients, we need to have antinuclear antibody test done, and almost all of them will have positive antinuclear antibody test, 100%, and antihistone antibody is the most specific antibody in drug-induced lupus. The condition is reversible. Upon discontinuation of the offending drugs, everything will return to normal, and this will be confirmed. The diagnosis after discontinuing the medication, symptom improved, this will confirm the diagnosis. The most common offending drug that causing drug-induced lupus are procainamide, disopyramide, probafenone, hydralazine, phenytoin, INH, minocycline, interferon, tumor necrosis factor. What about pregnancy in patients with SLE? First of all, fertility rate is normal in women and men with SLE. So they're able to conceive. But women with SLE are at increased risk for pregnancy complication, 2 to 3-fold more than normal women. The poorest outcome in patients with SLE occur in those who have underlying renal involvement. So we will advise all young age lady to not get pregnant until you have at least 6 months stable disease. This is for safety of a pregnancy. If patient has SLE and gets pregnant, which drug can be used or safe in a pregnancy? Glucocorticoid are FDA classified as group A drugs. It is safe to use in a pregnancy. Another drug, cyclosporine, tacrolimus, rituximab, listed as group C. Some say hydroxychloroquine, also a group C. Other drug, azathioprine, hydroxychloroquine, mycophenolate also can be used, but cyclophosphamide, methotrexate is absolutely contraindicated in pregnancy. Another entity needed to be addressed is neonatal lupus erythematosus. So suppose we have a pregnant lady who is known case of SLE. On doing antibody profile, she has anti-RO antibody positive, which one of the antibody that could be positive in SLE patient. That antibody has the ability to cross the placenta and go to the fetal circulation and cause a condition called neonatal lupus erythematosus. It is a condition characterized by skin rash, congenital heart block, and positive anti-RO in the fetus. So, because cardiac manifestation can be life-threatening, any pregnant woman who is now in case of SLE and has positive anti-RO antibody should be aggressively monitored during a pregnancy by fetal heart monitoring to permit intervention if any decrease in heart rate occurs. Recent evidence shows that during a pregnancy, women who had anti-RO antibody positive hydroxychloroquine treatment significantly reduce the chance that subsequent fetus will have neonatal lupus erythematosus. To complete systemic lupus erythematosus, we need to address its accompanying antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome is an acquired disorder that predisposes to thrombosis. So it is acquired autoimmune disease that predisposes the patient to thrombosis. The thrombosis could be venous, could be arterial. Also, patient with antiphospholipid antibody syndrome has recurrent fetal loss, recurrent pregnancy complication, also because of thrombosis of a placental vessel leading to placental insufficiency, and has thrombocytopenia. Antiphospholipid antibody syndrome could be primary disorder, occur de novo, or occur secondary or accompanying to other autoimmune disease, most commonly SLE, but could occur also with malignancies or drug-causing antiphospholipid antibody syndrome. Now, what about the pathogenesis of antiphospholipid antibody syndrome? Similar to pathogenesis of SLE, stressful condition, infection, or major stress like surgery, trauma, all these factors will increase apoptosis, same as SLE. But here the apoptosis is specific for the vessel or endothelial vascular wall and subsequent exposure of the phospholipid of endothelial cell to the circulation. The autoimmune system will regard this phospholipid as antigenic material and start to produce antibody, which is antiphospholipid antibody, and this antibody will react with the exposed endothelium to cause local thrombosis. How we diagnose patient with antiphospholipid antibody syndrome? But there is no specific test to diagnose antiphospholipid. The diagnosis is according to criteria needed to be collected. The criteria will be divided into a set of clinical criteria and another set of lab criteria. So clinical criteria, number one, we have to detect thrombosis. Any type of thrombosis, arterial, venous, or capillary thrombosis, which causing skin necrosis. Second set of criteria is pregnancy morbidity, which could be one of three. Either one or more unexplained fetal death at or beyond 10 weeks of gestation with no fetal abnormality, or one or more premature birth of morphologically normal unit before 34th week of gestation because of pregnancy complication, or finally 3 or more unexplained consecutive spontaneous abortion before the 10th week of gestation. While lab criteria, we have to demonstrate one of the three following antibody twice. I mean, when we detect antibody positive, we need to wait 3 months and repeat the test. If it's still positive, this is positive criteria. These antibody are lupus anticoagulant, anticardiolipin antibody, both IgG or IgM, and finally beta-2 glycoprotein I antibody. For diagnosis, we require at least one clinical plus one lab criteria to diagnose antiphospholipid antibody syndrome. Other features that could present in a patient with antiphospholipid, including thrombocytopenia, in vitro, only in lab, in the body it is normal. In vitro, prolonged active BTT, preeclampsia, pulmonary hypertension, skin manifestation called livedo reticularis. This is a picture for patient with livedo reticularis. This is another picture. Livedo reticularis consists of mottled reticular vascular pattern, purple in color. It's probably caused by obstruction of capillaries by small thrombi. So it is a sign occur in many diseases, not specific for antiphospholipid, and it's not among the diagnostic criteria, but it is helpful. How we manage patients with antiphospholipid antibody syndrome? because the main pathology is thrombosis, so we need anticoagulation. So we will start with anticoagulation, and because that patient is predisposed to lifelong recurrence attack of thrombosis, so anticoagulation need to be lifelong with target INR 2 to 3. Preferable agent is oral anticoagulation, warfarin. In women, during pregnancy, in order to prevent pregnancy complication in form of fetal loss or preeclampsia or even eclampsia, the preferable treatment is to start combination of low-dose aspirin and heparin during the entire pregnancy. Thank you very much.